Welcome, everybody, to Primo Perspective. We are here with our HIPcast friends, Shannan and Seth, and we're going to do another crossover since we had such great feedback from the last one. So, Seth, you want to kick us off with the first question?
Yeah, absolutely. It's kind of fun to get these questions from folks that are commenting on social media for HIPcast and to the Primo Perspective episodes as well, and then also just asking family and friends and saying, "Hey, if you wanted to ask Seth Johnson, healthcare expert or healthcare professional, what would you ask him?" And then he's got a group of friends that we get on a podcast and we talk about that question and hopefully be educational to the patient population out there and just anybody in general. We're healthcare professionals, and even we are surprised by some of these answers. So it's been fun, and I think this is going to be a series that we continue. So the first question comes from Sam, and Sam asks, why do I have to fill out what seems like the exact same paperwork every time I go to the doctor?
Oh, yeah.
Such a good question.
Yeah. It is.
It's a fairly standard question.
Because it is the same question. It is the same paperwork.
Yeah.
And we're talking about not talking about a new provider, right? We're talking about going to the same provider and having to answer the same questions and fill out the same things. Oh, so frustrating.
Yeah, and I can start it off a little bit there about how healthcare is, at least in the U.S., and it is in many cases everywhere, healthcare is not longitudinal. All right, that's a fun word for an East Tennessean to say, right? Because the way our system is set up, it is encounter-based, meaning we will see you and treat you based on today's encounter. Mm-hmm. We typically bill on today's encounter, and we will create the treatment path based on historical data that's coming out of the record, but primarily on what are you here for today? What can I do today to make you happy? And then how can I drop that bill? I'm oversimplifying it in many ways, but we are encounter-based in the way that we see a patient every day. With that encounter means we need you to fill out paperwork or fill out information, whether it's digital or via the good old hard copy paper documents, to provide us information for that encounter. And yes, you've provided that information before, but what if something's changed? Yeah. You know, your situation is very, very well known to you as an individual and as a patient, but there are many patients out there. I've got an uncle that has, he's on quite a bit of medication, right? And he sees multiple doctors, whether it's behavioral health or a kidney doctor or lung or whatever it may be. And those doctors are making adjustments. Those doctors don't get on a conference call every month and go, you know what, I wonder what old Danny's doing. Let's all talk about what his medications are. No, unfortunately, they're treating on an encounter basis as well. So as they make adjustments and he goes and sees another provider, well, you know what? That provider needs to know, what are you taking? What's new? What's changed? What's going on with this? And Mississippi, before we started rolling here, you even mentioned, sometimes people's insurances change somewhat multiple times during a year, whether it's a job change or Medicare. And you can probably expand a little bit on that. But I wanted to lay the groundwork there is healthcare is encounter-based, and that causes a lot of these problems and rework from a patient's perspective. You guys agree?
100, yes.
Well, yeah, and it's very frustrating. Absolutely.
It is. I think the number one driver, though, is going to be something Kristen's very in tune to, and that is the legal perspective of why this has to be done. So, Kristen, you want to talk about that?
Yeah. So, it's interesting because when I was thinking about this question and kind of going through it, we see where patients fill out anywhere between 15 and 20 minutes of paperwork every visit. So if you have a lot of visits, that's a lot of paperwork, right? And that question of why have I just filled this out on Tuesday and I'm here on Friday, why do I have to fill it out again? While we are encounter-based, we are also risk adverse. And that legal component of healthcare, we have to fill out this paperwork because of legal components along with compliance components. We have to make sure that you are who you are, that there's no fraud happening for this encounter. It makes me think about an encounter that I did have where we found A woman had given birth and nobody checked her paperwork accurately when she was accepted into the hospital. And 3 months later or 4 months later, she had another baby. That's impossible. But because of that's just one example of why we have to do this paperwork continuously and kind of monitor it. So, I mean, I know it sucks because that can be hundreds of documents that we fill out with the same paperwork every year. But
I'm thinking about, Kristen, I'm thinking about when you said 15 to 20 minutes of time, providers get paid on some things based on time. Should we be getting reimbursed by insurance companies or providers for spending that 15 minutes?
Yeah. Oh man, I know. I mean, that's like a solid doctor visit right there, though.
It is. You
know?
Right.
So, yeah.
Yeah. I think some of it too, because we have not necessarily changed the way we do things. Like used to, you had to have a 12-point exam, and a 12-point review of systems would get you the highest level. And the patient could fill out their review of systems, which meant you can say what symptoms you're having and things like that. And that could be scanned in the record and used to help the doctor do his portion of the record. And I think maybe sometimes we haven't necessarily changed that habit. So our forms haven't changed.
That's very interesting. And it kind of leads into the electronic forms and the electronic world, electronic medical record world. There's an old equation that we used to say in the IT space, which was new technology plus old process equals expensive old process. And healthcare is completely ingrained in spending millions of dollars to digitize or to create this new fancy solution that just is the old process, but much more expensive. And that's, in some ways, our failure in the electronic medical record world post Affordable Care Act and meaningful use and putting in EMRs the way that we did as a country. We incentivized a health system and or even down to the provider level of go digitize your records, do it now. Here's the money, and here's the timeline that you have to do it in. If you don't do it in this timeline, we're going to start taking money away from you. So everybody rushed into this EMR world, and that's created basically hundreds of thousands of silos of information across the country with information that you can't necessarily move back and forth to each other. And, you know, Kristen, you even mentioned the legal aspect of why we have to do the encounter-based stuff, but there's legal ramifications when I have all my information in a silo.
Yes.
Yeah, I think I've used the example before, Shannan, on some HIPcast episodes of it would have made total sense. And that's a total sense and government that I'm about to go into never combines. It would have made total sense for the DOD or the Defense Health Agency and the VA to be on one instance of an electronic medical record, right? But what did they do? They said, well, we're going to go spend $18 billion for active duty, but it's going to be ours and we're going to build it for us. And then the VA said, well, we're going to go spend $15 billion and it's going to be ours and it's going to be for us. Then the Coast Guard said, we're going to go spend a few billion just for us as well. Now, none of those systems talk to each other in an efficient manner, and we've created this massive issue for active duty moving to VA service. And that's just one example. Now, you multiply that by all kinds of providers across a community and a health system, and we can't get information to move back and forth easily. We can do some, but we can't get information to move back and forth. And I think that, to go back to that wonderful word that I used to begin with, that's one of the reasons we don't have longitudinal care for a patient across a bunch of providers.
I think you just like saying that word.
I do. It's one of the few I can pronounce.
You tapped into something, though, Seth, that I have always found to be a bit of a conundrum, because you used the different components of our military and how we're not connected. They have to fill out the same paperwork when they are here, when they go to a private facility, and when they're overseas, because we are not able to communicate. It's legally impossible for us to right now to communicate technology wise across all three of those components, because there are such heavy roadblocks between the technology communicating. When you speak internationally, and so somebody who's on active duty, and let's say they're in Kuwait, they have an instance over there or an encounter over there that they have to do. They have to bring their paperwork with them because they cannot transmit that into the US. We're not allowed to. Our frameworks don't allow us to do that. And so that's even more of a bottleneck when it comes to the paperwork and how much patients have to fill out. So when you add in our military and what they go through, I mean, there's this like exponentially worse. Mm-hmm. That 10 to 15, 20 minutes doubles, triples because they're doing the exact same process everywhere they go. It's insane.
So last week I had a doctor's appointment. It's the doctor I've been seeing. I went to go do everything online to get my stuff submitted. 16 screens. It asked me questions. I could not skip them. It was questions I'd already answered. And I was thinking, why don't we just have a button that says nothing's changed? Because nothing really had changed. I had not seen anybody else. I hadn't started new medicines. But then I think about, well, if you don't prompt people, how many people are just going to say nothing's changed when really there has been changes?
Yeah.
For
me, button every time.
Yeah, I'm going to hit nothing's changed every time. And then you get in the back and you're telling the doctor, they're asking about meds, and you're like, oh yeah, I started taking this and I'm taking this and I had this surgery, since the last time I saw you. So it is a patient safety concern as well when you start looking at it from that standpoint of a lot of us are going to take the easy way out and say nothing's changed.
That could be an order of operations thing, Lorie, in formatting, right, in the form that you're filling electronically, because you could say simple things like new meds, new providers, new conditions, new symptoms. And then when you fill all that out and you have like a anything else opportunity, and then that person clicks the button, no other things, then it pops up. Now look at all of this, the demographics and whatever it is, right? Health insurance and stuff. Is all of this the same? Because then you take care of the critical issues in terms of clinical. You could even put the insurance information on the front before that kind of order of operations. Then a person doesn't have to fill out history all over again. Not only have they filled it out multiple times, it's also in the provider's records, and it's probably on the problem list that they're copying and pasting forward. Shh, I didn't say that.
Yeah.
But you are correct. You are correct. Yeah.
I do think the patient portals, though, where patients are given a link that they can go in and fill out, you can scan through and click nothing's changed on each page. Now, 16 pages, you're still scanning through, but you're not necessarily filling them out.
Right.
So
that's true.
I think there's
the problem is we're also conditioned. Well, I'll admit that I'm conditioned that, I officially, it's a Jim Gaffigan joke, so I'll give him credit. I officially accept all terms and conditions on the internet. Stop asking me. Like, yes, I'm logging into the service to do it, to use it. I officially accept all the terms and conditions. Yeah. But from a legal perspective, we've got to have that done. From a patient record perspective, we've got to have that done. Shannan, you typically bring in a really good payer aspect into a lot of these conversations. We've talked about it from the provider perspective and a little bit on the patient side. Is there any reasoning on the payer side for all of these things to be filled out each time?
Well, I mean, I don't think there's a good cause for it to be filled out on the provider side, so I surely wouldn't think on the payer side,
That's fair. Yeah.
Not really, because if you think about the data that goes to the payer, it's the claims data, and on that claims data would be that person's member ID, so we would know how to associate it and attribute it to the right member, so the patient matches the member at the plan. But we're not getting the updated demographic information. So if the patient has changed addresses or phone numbers or all of that, that's not helping the payer know that, because we get essentially the demographics of the provider in terms of contact information. But for the patient, we get their name and their date of birth, things like that. But it's member ID that we're really associating. And I don't think we get, I don't think we have like the demographic information update. And if we do, Lorie, on a claim that goes to the plan, does the patient's address go? I'm trying to see the 1500.
I'm trying to picture a 1500.
I don't think the address goes on the 1500.
So.
I don't think the address goes.
But
then even if it did, as far as I know, there's not a standard process for reconciliation on the payer side where when that 1500 comes in, those are not the forms we're matching on the member ID and date of birth and such. We're not really matching on the address. So from that perspective, it's not adding value for the payer that I can think of. So,
well, let's not
I just think it's a terrible idea.
I do too, because it would be another reason to deny a claim. Their address does not match, so we're going to deny this claim. So yes, let's not give them another reason to deny anything. Okay.
I just think we need to be more logical. Instead of holding on to all the legacy things that we've required, even Kristen, from that legal perspective, let's hone in on the things that really do help us with risk management instead of the whole slew of everything that's part of that legal and compliance requirement. What is really important that gets updated every time, right? The new symptoms, absolutely. New medications, absolutely. A new provider visit, maybe. Depending on what that provider visit was. I mean, if you're seeing me for management of diabetes and hypertension and I hurt my foot, that's important to the diabetes. But if I don't have diabetes, that's not necessarily important because I have a broken toe and I'm seeing an orthopedic or whatever. So there's an opportunity to limit the amount of, we could go down from a reimbursement for 15 to 20 minutes to 5 minutes. Okay.
Right.
That's what I'm saying there. It's crazy to me.
Because what typically happens is you fill all this paperwork out before you go back, and then the nurse turns around and asks you the exact same questions about the medicines. And that makes me crazy. And y'all, my daddy's something. He'll look at the nurse and he'll say, "It's in the computer. Can't you look in the computer?" And I'm thinking, Daddy, don't be ugly to the nurse. She's doing her job. Well, she can look. I've already told them this. It hadn't changed. It's the same.
I feel that.
That is the frustration from the patient side that we all have felt going in there and doing that paperwork. But that, we kind of lean into the payer side and the frustration piece there. And, something that I always hear people, especially on the patient side, talk about and share frustrations about is this term prior authorization. So we did get a question from Lorie, who said, "Why do I sometimes need prior authorization from my insurance company before my doctor can order a test, medication, or procedure, even when my doctor says I need it right now?"
To keep you from getting taken care of. That's what I'm going to say, because I'm a provider.
Before I go on a monologue, does anybody want to add anything here?
Go ahead, Shannan, and I'll jump on.
I'm telling you. So number one, bottom line is just controlling healthcare spend. Like, that's prior auth in a nutshell. We have to manage,
You're speaking from the
universe. Say again, Seth?
You're speaking from the payer's perspective?
No, from the universe of things, right? Because even on the provider side, if I didn't get prior auth for this thing, I'm not getting paid. So this is important. This is important to everybody. And on the patient side, Lorie, remind me, on the patient side, if I didn't get prior auth and the health insurance company denies it because there wasn't a prior auth, and the patient didn't sign some kind of an ABN or something, they still have to pay for that? Or if it's not approved, it's written off completely and the provider just loses? Okay. Yeah. So number one, it's control of healthcare spend. And when I think about when prior auth kind of started and the reasons it started, I could get on board with supporting it. It made sense to me. That doesn't mean it hasn't been abused since, right?
Yeah.
It is definitely harder to get some things. And if you have a provider, there's a requirement for peer-to-peer sometimes, meaning a physician at the provider's point of care has to have a call with a physician at the payer's company to go through all the clinical steps and protocols and why this person needs this exam and things like that. So while I remember how this started and why, and I could get on board with that. All of the unintended downstream consequences that happen definitely happened here. It's hard. It started because of unchecked or redundant tests. Sometimes those redundant tests were necessary and sometimes they weren't. There was a lot of waste and a lot of abuse there. I wouldn't say prior auth started because of fraud. I would say that prior auth started because of waste and abuse more so. Do you guys agree with that? Do you think that's true?
I do. I do think that's true. One of the facilities I used to work at, they had a family practice doc. I know he had patients that had nuclear stress tests like 4 times a year, 5 times a year.
Mercy.
A lot of isotopes.
Yeah, it's like you if yours was negative in January, it's probably going to be negative in March. So he would do things like that. And to your point, yes, I think that's why prior authorization started, is because of that. But I have a great story. I always have a story. I have a great story about prior authorization and just the frustration from a provider. So we had a patient come in through the ER, unconscious, having a myocardial infarction, heart attack, MI, comes in, they get him to the cath lab. He codes in the cath lab. We get him taken care of, get him sent to ICU. He's in ICU less than 24 hours. I think it was like 18 hours, something like that. Passes away in ICU. So we billed it as an inpatient stay. Okay. The payer comes back and denied inpatient and said they would pay it at outpatient. So then we filed the outpatient claim, and they denied it because we didn't have prior authorization for the heart cath.
Mercy.
And so by the time you fight all of this, and then you get timely filing and things, and we just absorbed the cost of it because it was taking too much effort, administrative effort, to try to get the dang thing paid than what we were actually going to get paid for.
And the family all along is still grieving, but then they're also starting to receive communications from either the payer and or the provider of, here's what's going on. You guys are in the fight for trying to get this done because the insurance company asked for this old fella to have his heart attack prior authorized.
Correct. Yes. And so those are the kind of things
Maybe
that
I
we
need to
see.
swipe my insurance card every time I walk into the Chinese buffet to get prior authorization when I go in there.
Yes. If it were only the Chinese buffet, right, Seth?
Yeah. That's funny. That is funny. And
don't swipe it when you go to Howl at the Moon, okay?
Well, yeah.
Prior auth we see all the time where we're running into issues, and so we would have patients that, they needed, a doctor would order a CT stat. They thought maybe the patient had appendicitis and they were needing to get that CT stat done. And you call and you try to get authorization, or you go on the portal to get authorization, and they tell you it'll be 3 to 7 business days before they can let you know. And you're like, I think my patient may have appendicitis. Well, the trick here is you've got to do labs. You got to do a UA. You need to do these other things that's going to support having the CT done.
Yeah.
And I think we don't always think of that. And providers, you have to have a documented note. So if you're sending a patient stat for a procedure, you've got to already have your physician clinic note completed and signed and in the record so that they can send that to the insurance company as well. So
that's a good point, Lorie. If you've got the supporting documentation, then it's easier to get that emergency prior auth, right? If I've got a patient that isn't registering white blood cells in that case, then they're not going to get it. But if I've got a patient with a 20,000 WBC count, then we're golden. Probably.
But if I'm a patient laying there on the bed,
I'm
hurting.
I could care less.
You just want to be fixed.
I just want relief, right? And there's this whole process going on, and it's typically a fight, but both sides are fighting for what they need to either get paid or to pay.
Right.
And you're just sitting there going, why is this taking forever? Well, there's a fight in the background going on. And that's a major issue that we have in this in the healthcare space today. But from a patient's perspective, let's take the emergency scenario off the table. Let's say I need to go have I don't know, a colonoscopy or whatever, right? I just need a general procedure done, but yet I have to go get a prior authorization, what's your advice to the patient population of why do I have to go through this? What should I do to say the right words to help my provider and my insurance company in these scenarios? Any advice there?
Yes. You've got to be very descriptive about what's going on with you. Your provider's got to be very descriptive about what's going on. And patients need to understand, unless it is an emergency, it doesn't happen overnight. No. Just had this actual happen at a client. Doctor ordered a CT. Radiology department scheduled it for 14 days out because the insurance company says allow 7 to 10 business days for a decision on non-emergent cases. The patient gets very frustrated and upset, gets on Facebook Live and starts dogging out our facility because we are not doing our jobs. We're not getting, the authorization quickly enough for them to have their test, and going on and just really talking down the facility, when in reality, they're doing everything they could to get it authorized. And if they would have gotten it sooner, they'd have called the patient and told them, rescheduled them to come in. But that's just it. This is not a 24-hour turnaround for these authorizations. Sometimes it takes days and days, and then you have to submit additional clinicals to support why the patient needs the test. And I think our patients, we're all about, in society, I want it now. It's got to be now. I want it now. I'm as bad as anybody else. I want it now. And we're to that point of it's just causing conflict all the way around because we want instant gratification and to know right then. And it doesn't work that way in healthcare anymore.
It doesn't. Let me ask you all a question, because I want to take it past kind of the clinical component and go back to what I started with in the beginning of this part of the discussion. The bottom line is the dollars, right? So a question for you all. I don't know the answer to this. I don't know if this has been studied or not. Do you think that prior authorization did prior authorization practices when they were kind of mainstreamed in the late 80s, early 90s, do you think they had a positive impact on fraud and waste, or waste and abuse? Let me start there, waste and abuse. And then has that kind of waned over time and we have less of an impact, or do you think it still has impact? What do you think about that?
I was in elementary school, so I can't talk about the 80s and 90s. I was in elementary school eating square pizza.
I still eat square pizza. Who cares when it was?
So I'll defer to the rest of the group. Yeah. Kristen, I think you're probably on my side, but
yeah.
Oh my goodness.
Yeah, Shannan, I dislike them right now, don't you?
I do too, buddy. I'm with you.
Let the grown-ups talk.
Talk. We'll sit at the card table and let you all talk.
So actually, Shannan, I agree that when it originally started, it did impact the fraudulent claims and the abuse that was going on. I really do think it has. Now that it has been determined that companies can make money off of doing prior authorizations, because no insurance company does their prior authorizations. They're all outsourced to third parties usually. Like imaging,
the majority are
to third parties that are charging these payers to do these services for them. So when we found out we could make money in it, we've made it way more difficult than it really needs to be. Shannan talked about peer-to-peer earlier. One of the biggest frustrations with providers on doing peer-to-peer is I am a geriatric family practice doctor. And I call, and the provider I'm doing a peer-to-peer with is a pediatrician or a general surgeon who has
or an obstetrics.
Or an obstetrics guy who has minimal knowledge of geriatric care and what needs to happen to those patients. And that is one of the biggest frustrations, is that true peer-to-peer is, if I'm a family practice guy calling, I need to talk to family practice. If I'm a neurosurgeon calling, I need to talk to another neurosurgeon, not a GP or somebody like that. So that is one of the biggest complaints about these peer-to-peers. And literally, they'll tell you peer-to-peer is, we'll call you back between the hours of 8 and 5 on Friday.
Yeah.
And so you're trying to wait. Okay, so when does this peer-to-peer? It's kind of like waiting for the cable guy.
Cable company,
they're gonna show up at some point. You just don't really know when. And can you imagine trying to practice medicine when you've got to you've got to do a peer-to-peer call and you're just not real sure what time it's going to come in? So patients don't understand that either. I'm in your office. You're seeing me face to face. Why are you stopping what you're doing to go talk to an insurance company?
Yeah. Yeah, it's a hard challenge. So I do think, Lorie, for sure, in the beginning of this, that providers being required to have a prior authorization for some of those overutilized tests, because when it started, it was a small number, right? It was a small, maybe some MRIs and some different things like that. It wasn't a huge amount. Now the prior auth has grown to include so many more procedure codes than it did before, and so that's a challenge. And so for the patients that might be listening or caregivers that might be listening, so far what we've been talking about is what's the purpose of filling out all the documentation again? What's the purpose of prior auth and how does it impact me and why do we have to deal with this? It started as a good thing, but the unintended downstream consequences is that it grew into a revenue machine for third parties, and so that hurts us. And it's a game we have to participate in to get the care. The only other option is to go private pay, which is kind of funny. Nobody checks the private pay fraud, waste, and abuse, right? Nobody looks to see if patients are getting private pay patients or cash pay patients are getting charged for tests, having tests done that are not needed. So it's interesting because sometimes providers are a little more cautious about ordering tests for those patients because they are cash pay. So it's just a big vicious cycle of everybody has to play this game and nobody likes it. Like, I really don't think anybody likes this game that we all have to play.
No, we don't.
But I want to take it now, if you guys don't mind, just go for a couple of minutes with me into the health information professional world here. I think about fraud, waste, and abuse, and we've talked mostly about waste and abuse to this point, but I want to talk about fraud for a minute because, I could talk about this for a long time because it infuriates me. Because fraudulent providers, whether they're real providers or fake providers, filing claims on conditions or procedures that are erroneous completely. Either no patient exists or a patient exists and they're giving false diagnoses or, billing procedures that weren't performed, things like that. That definitely has a massive impact on cost. I think the health plans across the country, across the lines of business, meaning Medicare, Medicaid, commercial, there's an estimated $3 to $6.8 billion recovered every year from just general health plan audits. This is not the government cracking down on the spend. This is just general health insurance audits where they recoup money. Now, I'm not saying all of that money should be recouped because I know that sometimes there are cases where they should not have recouped that money. The documentation that's needed to support that is there. But there's real fraud cases that are identified in these situations. And so, but beyond that component of the healthcare spend right now and the healthcare fraud that's generating all these new dollars, what maybe bothers me as much, at least, if not more, is the erroneous and wrong diagnosis and procedure codes that are associated to a person and attributed to their medical history for the rest of their life. Think about that for a second. So you guys might not be familiar with this kind of practice, but we look at in healthcare, and I've done this really in payers world and in providers world, looking at the diagnoses that were attributed to my case mix, right? So it's about case mix essentially.
Right.
But my patients have this condition, and the average patient with this condition in this age range costs X dollars per year, right? Well, if I think about the increase in autism in Minnesota, which is under investigation about whether or not that's real, right? I'm not I'm not saying it isn't real. I'm saying it's under investigation about whether it's real or not. So alleged erroneous false claims and fraud. Think about 400% or something increase in patients diagnosed with autism. Well, that diagnosis code or those diagnosis codes related to autism is going to follow that patient for the rest of their life, which is not good for that person as a grown up trying to do the things they want to do. Probably not going to ever be in the armed services. Maybe they don't want to anyway. I don't know. But then beyond that, actuarial services are trying to determine what does my patient mix look like, and what is that going to project to cost me in next year's healthcare spend, and how do I adjust my premiums? Like this is how detailed this gets. I'm going to adjust my premiums based on what I know about my patients from this year or from these years for next year's premiums. Like that's a big problem. That's a huge problem. So I'm going to stop because we're getting like along in minutes
for the
here.
Patient episode.
Yeah. That's why I moved us in through the healthcare. But what do you guys like? Do you have any thoughts on that from how it impacts the patient? Not just the spend and the projections, but that diagnosis is going to follow that person. How do you correct your record?
So I got a great example, another story. So back in 2021, I had vasculitis and I got diagnosed with C1q complement deficiency.
Okay.
So I had gotten retested 2-3 years later. My labs were normal because they think all of it was attributed to the vasculitis. Okay. Nobody removed that diagnosis off my problem list. So last year I was in the doctor and they said, you need I think it was a hepatitis vaccine. And I was like, okay, why are you giving me the hepatitis vaccine? Well, because you have a diagnosis of C1q complement deficiency. And I said, okay. And so I told him the story of I had that when I had vasculitis. They retested me and my levels were normal at that point. And he said, oh, well, that's the only reason I was going to give you that vaccine. He said, let me just take that off your problem list and you won't have to get the vaccine.
And patients have no idea about this.
They have no idea.
No idea.
The only reason I knew what it was is because I am in healthcare and I paid attention, and but a normal patient wouldn't have known that really didn't have that condition.
We have to watch our diagnoses and procedures that are coming on, that are in our record or coming on our EOBs or whatever. Actually, I don't think on an EOB you don't get a diagnosis, do you? Don't you just get the procedures?
Procedure codes, yeah.
Gosh, it's a challenge.
It's a challenge. So from a patient's perspective, though, there's a reason why we have you fill out the forms every time you come in, because we need that information to try to manage this complexity. And there's a need, unfortunately, for the prior authorization process and all of that documentation that needs to go with that, whether it's good or bad. There is a process, unfortunately, that has led to all of this. So when you think about your healthcare space and going and visiting the doctor, know that it's very complicated. Know that there's a team of people that are working behind the scenes to try to make sure that you get the best care as much as possible, as fast as possible. But there is a long process. So, Kristen, do you want to wrap us up here on Primo Perspective?
Yes, I do want to say one thing before I wrap up, though. I think patients need to exercise their rights, and maybe they don't know them. So let me just tell you, you can go get your encounter visit. You can see those records. You can view those records. You can ask for changes and addendums to them. So if you are in that situation, and use technology, I know a lot of people say don't, but use technology when you don't know what something is. ChatGPT, Claude, Google, they all can help you understand that. And if it does not resonate with what you're experiencing, then you really do need to stand up and say something's wrong or find somebody. I have friends who came to me. He doesn't have insurance. He needs help negotiating what to do. Come to somebody who knows, like one of us or somebody else who's willing to help you step in and be that advocate for you. Because I think patients forget they have power. They just don't know what power they have, or they don't know how to exercise it. So that's my ending thought. I love these sessions. It's really great to learn from each one of you. And thank you for doing the crossover and send in your questions. We're excited to get them. All right, team. Till next time. I'll see you later.
Later.
Bye.